Okay. Eye surgery was what? BSS, right? Don't forget the BSS. There's a lot of little things too that we need to remember. So please, guys, when you come in here, come ready and as ready as you can. Please don't sit here and expect someone to tell you how to do surgery. You should have a better idea. What you practice here is the same as always. Aseptic technique, 100%. That's what I want to get out of here. If you guys can get out of here doing a cataract surgery, yes. If you can get out of here doing a carotid endarterectomy, yes. Okay, that is great. If you don't, let's not worry about it. You're gonna have enough time to actually go through these rotations and have a better understanding because the actual human is there. The actual surgical patient is there. So you're gonna be able to practice a little better. Hopefully it does. These guys, it was a wake-up call when they left here and got there. Oh, this is real now. Everything clicked. Everything started to make sense. The awareness, the where you move, the where you don't go. Why? Because there's a little awareness, the nurse, that tells you, hey, stop doing that. Back up. So there's going to be someone there to catch you. But by all means, you should know how to react right away. When someone says you're contaminated, where? Let me stop. How do I fix this? Okay? Definitely not. Oh! Continue. Okay? So again, that's what I want you guys to get out of here. So please don't let this intimidate you. By the way, these two are some of the easiest procedures you can do. Okay? I said that about DNC, right? Some of you guys go, oh. Okay. DNC is one of the easier procedures you can do. In and out, merigotomy, in and out, TNA, and there's a couple more things. It's a lot more technical nowadays. But it is an in and out quick surgery. These are the surgeries where you're going to see one and then automatically do and teach one for the next one. You right? You text, you guys were there. What do they do? Here, show you how to do a TNA. Next thing up, go ahead. You're good. Go for it. All right, these are the ones that are going to be asked a lot during your CST also. Okay, I made you guys difficult, so you guys got a little bit of everything. But normally they like to add a lot of these instruments in here because they know for a tech, for sure, you're going to be doing these cases. For sure. Yeah. Okay. Why? Because they're easy. They can throw almost anyone in there. Okay. ENT doctors are usually a little bit more patient, a little bit nicer, right? You guys have kind of dealt with that, right? Yeah, they're a little bit more nicer, a little bit more patient. So they end up throwing a lot of new hires in. I mean, I remember getting thrown in with one day of being in a new hospital to go do a cochlear implant. We implanted a cochlear device so they can go inside to the cochlea that's in there and apply some wires and blah blah blah. Very first day, no precepting, I was able to wing it. Okay, why? Stick to the basics. That's what we got to get with today. Let's learn the basics of ENT in order to survive wherever you guys go. All right, so ENT packs. What's inside? You're definitely going to have basic stuff: sponges, Raytech, laps, blades. Right? What blades do you guys think you're going to have more of them?
15.
15. Very good. We're dealing with ENT, smaller areas, right? Should you ask for a 10 blade for a certain surgery? Yes, right? What is an example of asking for a bigger blade? Why? Basic terms.
Tonsillectomy.
You have an open surgery, right? 10 blades gonna make what kind of incision? Small or big? All right. Might you need a 10 blade for ENT? Yeah. Sometimes they cut the back of the ear open to move that forward, so they can work inside the middle ear and around. I know I haven't got to do some of those cases. Did you get to do some of those cases? Pretty cool. Big incision, small instrumentation. So you're gonna get a whole table worth of instrumentation. Okay. On top of that, you might have an extra pack or an extra table drape to drape a separate table so that you can have all your implantation devices. It need be separate from the whole mess you've created. All these instruments are smaller, so you're gonna need to spread them out. Being smaller means the tray looks smaller, but when you open it, there's a bunch of stuff that you need to spread out. So you might need a bigger table. Okay? And definitely you want a clean area, because if you notice, this area is kind of saturated with all these instruments. You want definitely a clean area for implantation. Don't worry about this case that we're talking about right now, but for ENT is what okay? This is TNA. You're hopefully not implanting fake tonsils back in there for cosmetic look. Okay, so again, other things you might see in here, syringes. For ENT and plastic, you're going to see a lot of control syringes. I didn't see any for these packs, but you might end up seeing the control syringes. Your drape is going to be different. Are we going to have a laparotomy drape for ENT? What drape do we usually have? a U-drape or split drape, right? An ENT split or a simple U-drape. The difference, guys, between a split and a split is usually smaller. A U has more of a U shape, a little wider. So orthopedic usually uses the U's, and anybody else uses the splits. Okay, split sheet compared to a U. It's still the same type opening, right? It's still the same adhesive. It's still the same way you drape. So we're gonna practice that today. What might also be in here, it wasn't in these packs. By the way, these were brand new ENT packs, okay? I have one more, I think, or I have 7 more, or I'll have you guys play with that one if you guys want to see a brand new one. But also you should have towels. This thing had a lot of towels because we're gonna apply a turban drape. And we're gonna do the old school turban drape. For one, I didn't see the new one here. But if you know how to do it old school, you should be able to do it new school because everything says grab here, pinch here, flap, flap, stick, and it has little stickies instead. You're good to go. I think you got to use those, right? Pretty easy. And guess who does the draping anyways?
Surgeon.
Surgeon does it anyways. But in a pinch, you guys should know. Why do you guys want to know? So that you can do what? What's that word, the A word that I'm looking for?
Assist.
Anticipate. Very good. So I'm going to show you guys how to do it the old school way. And then ENT, guys, there's very big variations of instrumentation. Again, they might be just an auto or ear tray. There might just be a nasal tray, or again, septal tray being in this case. We're not going to be doing plastic surgery on the nose. So I removed that plastic surgery video, guys, for the nose. It was an ENT procedure, but they were also doing a lot of reconstruction. The difference between ENT and plastic, septo is ENT, rhino is plastic. So cosmetic look and an internal fixation for actual breathing and stuff is going to be ENT. So we'll focus on ENT next week once we start getting into OMF and going into plastic into your next term. So we can get a little bit of plastic that way. OMF we're not going to do, by the way, guys. Or we're going to try, but we don't have the stuff to actually do an OMF procedure. We need a bunch of little screws, wires. We do have the mouth wired shut over here, but we don't have the wires anymore. They used all the last wires on. We'll explain it. Okay. All right, other things too in working, the packs that you might find, you might end up finding a throat pack inside your guys' ENT packs. Okay. Anybody know what a throat pack can be? Just think of the words.
The tonsil wraps?
No, what can it be? What is it doing? Throat pack. Pack in the throat. Vaginal pack. What does a vaginal pack do? Pack the vaginal cavity. Okay. So what do you think a throat pack's doing?
Pack in the throat.
It's not stopping bloody. It's not stopping blood. Okay. What's happening is it's preventing anything from entering other cavities. What are those other cavities? What I'm talking about?
Windpipe.
The lungs and
Stomach.
esophagus, stomach. We're really more preventing stuff going into the stomach. Because what's in the airway anyways? What should be? Tube, right? A tracheal tube. Right? Endotracheal tube or a nasal tracheal tube. Okay? Something that's gonna go and it's gonna block that off anyway. So the throat pack really is for preventing any or a lot of fluid entering the stomach. What can happen, guys, if we don't do that?
Locked.
Nausea, vomiting, right? Aspiration. Yeah, a lot of people have died from ENT surgery from aspirating later, even when they go home. Okay, a lot of times they do recover. They should be recovering for at least an hour in the hospital, and then they throw up and your nurse comes and suction all like that. But then they go home because they had all these blood clots that are now stuck on the stomach. They get nauseous and then they start throwing up, and then there's no one at home. What do? Choke. So we try to prevent that. Knowing that that might happen, we put in a throat pack. Anything goes into the body, what must we do? Count it.
Contents.
So yeah, you need to get it out. So what's a good way of reassuring that you know you're going to get it out? Count it. Have it on the board somewhere when it goes into the body. So if that way your nurse at one point can say, hey, you guys ain't done yet. We have a throat pack in. Oh, yeah. Actually got into a situation. Let me give you a quick story. Anesthesiologist, horrible, no longer anesthesiologist because of this. He actually forgot that there was a throat pack in. Now, he neglectfully forgot because the nurse and I yelled it out several times. There's still a throat pack. There's still a throat pack. I'll get it out later.